Today, we're going to break down some of the most critical skills in nursing. We're starting with the absolute fundamentals of IVs and fluids, and then we're building all the way up to navigating a life-or-death transfusion crisis. Let's just jump right in.
So, here's our roadmap. We'll kick things off with the basics of fluid balance, then dive into what happens when IVs go wrong. From there, we'll raise the stakes with blood transfusion safety, walk through an emergency reaction, and then we'll wrap it all up with a rapid review so you've got this stuff down cold for your exams.
All right, first up, fluid and IV fundamentals. The easiest way to think about this is to picture the body as this incredibly complex plumbing system. This whole section is about understanding that system and the tools we use to manage its pressure and its volume.
Here you can see the two extremes of fluid balance. On the left, you've got a fluid deficit, or hypovolemia. Think of it like the plumbing is running dry. The body is struggling to keep the pressure up, right? So you get dizziness when you stand, a weak and thready pulse because the heart's working overtime, and dark urine as the body tries to conserve every last drop. And on the right, it's the total opposite, fluid excess. The system is overflowing. That causes a pounding, bounding pulse, bulging neck veins, and you can even hear fluid backing up into the lungs as crackles.
Now this little equation highlights the single most reliable tool we have for tracking these fluid shifts: daily weights. The rule is just so simple, but so powerful. A 1 kilogram change in weight, literally overnight, equals a 1 liter fluid gain or loss. It is the gold standard for a reason. Okay, this is where things get really cool. We can actually manipulate where fluid goes in the body just by using different IV solutions. So isotonic fluids, like normal saline, they're balanced, just like our blood. They just stay in the bloodstream and add volume. Easy enough. Hypotonic fluids are more watered down, so they cause water to shift into our cells, to hydrate them. And hypertonic fluids, they're super concentrated, so they do the opposite. They pull water out of swollen cells and back into the bloodstream. Each one has a very specific job.
So IVs are our go-to tool for managing fluids. But what happens when things go wrong? Let's look at a couple of common complications, because spotting these early is absolutely critical.
This is a classic comparison you have got to know. The key difference really comes down to one thing: temperature. Infiltration is when fluid leaks out of the vein into the tissue. That makes the site all swollen, pale, and cool to the touch. Phlebitis, on the other hand, is inflammation of the vein itself, so that site's going to be red, tender, and warm. Cool versus warm, that is your number one clue.
So here's the thing. Whether you find that cool, infiltrated site or that warm, inflamed one, your immediate actions are exactly the same. First, you stop the infusion. Don't slow it down, stop it completely. Second, you pull that catheter out. That line is done. Then, you restart a new IV, ideally in the other arm, and finally, you treat the old site by elevating it and applying the right kind of compress.
And this right here is a massive safety trap on exams and in real life. You never flush an IV line you think has gone bad. If it's infiltrated, all you're doing is forcing more fluid into the tissue, causing way more damage. And if it's phlebitis, you could actually break a tiny blood clot loose from that inflamed vein and send it flying. It's a critical safety rule. Don't flush a bad line. Okay, now we're going to escalate things. We're moving on from basic IV fluids to one of the highest risk procedures in all of nursing, giving a blood transfusion.
This quote, it just perfectly frames the mindset you need to have. This is not just hanging another bag of fluid. You are literally introducing foreign, living tissue into your patient's body. The potential for a catastrophic immune reaction is always there, which means your margin for error is absolute zero.
With stakes this high, these pre-transfusion checks are completely non-negotiable. First, you need a nice large gauge IV because a small one can actually crush and destroy the red blood cells as they go in. Second, you can only prime the tubing with normal saline. Anything else can cause the blood to clump up or burst right there in the line. And finally, you have to do a two-nurse verification at the bedside. It's an absolute must to prevent a horrible mix-up.
The moment you start that infusion, a clock starts ticking. You take baseline vitals right before you start. Then, for the first 15 minutes, you do not leave that patient's side. This is the time when the most severe, life-threatening reactions are most likely to pop up. And finally, the entire bag of blood has to be completely infused within 4 hours. Any longer, and that blood becomes a serious sepsis risk. So, what happens when, despite all of our safety checks, the absolute worst-case scenario unfolds? This is where you have to recognize and respond to a full-blown crisis, and you have to do it fast. An acute
hemolytic reaction. It's just a brutal, body-wide event. The patient's immune system basically sees the donor blood as a foreign invader and wages war on it, shredding the red blood cells. The debris from that battle then flows through the bloodstream and starts clogging up the tiniest blood vessels like sludge in a pipe, especially in the kidneys.
Your patient is going to tell you something is terribly wrong. You'll see sudden chills and fever. Their vitals will start tanking towards shock, fast heart rate, dropping blood pressure. But the hallmark sign, the one that should make you scream ammonia hemolytic reaction, is that sudden, intense flank or lower back pain. That is the physical feeling of their kidneys getting clogged with junk, and it is a massive red alert.
If you see those signs, you have to act instantly. First, stop the transfusion. Then, and this is the most critical step of all, you completely disconnect the blood tubing from the IV hub. Don't just switch to the saline on the same Y tubing. Get that contaminated line away from your patient. Next, you attach a brand new, clean tubing set and run in normal saline to keep that vein open. Then, you call for help.
All right, we have gone all the way from basic fluid management to a full-blown emergency. Let's wrap this up with a quick review of the absolute must-know takeaways from all of this.
Here it is, boiled down to the essentials. For IV complications, just remember that temperature check. Phlebitis is inflammation, so it's warm and red. Infiltration is leaked fluid, so it's cool and pale. For transfusions, if you even suspect a reaction, you stop the infusion, you completely disconnect the old blood tubing, and you keep that IV line patent with a brand new line in normal saline.
Okay, time to apply it. You walk into a room. Your patient is getting blood. They tell you they're shivering and have a sharp pain in their back. Their heart rate is 122 and their blood pressure is dropping fast. What is your immediate sequence of actions? Think it through, step by step.
The correct action is exactly the protocol we just covered. You stop the blood. You disconnect that contaminated tubing entirely. You get a fresh, new line with saline running to keep that IV open for emergency meds. Then, and only then, do you call for help. That sequence prioritizes stopping the harm and maintaining access for the rescue.
And this slide shows you exactly why that specific sequence is so important. If you just switch the Y tubing to saline, you'd be using that new fluid to flush all the remaining incompatible blood from the line right into your patient, making the reaction 100 times worse. You have to completely remove the source of the problem. So I'll leave you with this final thought. A minor febrile reaction and a deadly hemolytic reaction can both cause a fever. But what is the one sign that tells you this is a systemic attack and your patient's kidneys are in immediate danger? That's the sign that changes everything.